Thank you very much for the introduction. Can everybody hear me? Yes, good, perfect.
Yeah, much better.
I'm actually going to scroll really quickly. Ignore all this stuff. Don't worry, it's not as long as it looks. To the very last, oops. Oh, crap. I don't know, mouse.
Minor technical difficulties.
Minor technical difficulties. Realized I didn't have a mouse. I wanted to actually scroll really quick to the last slide first. Just to kind of briefly mention the Center for Pediatric Obesity Medicine. I'm going to be talking a fair amount today about kind of the different projects and work that my specific program is looking at. And so I just wanted to kind of acknowledge all the work, everything else that's been going on with the Center for Pediatric Obesity Medicine, the department, the vision, everything else. So I wanted to actually start with there. But now, let's get back to the very beginning. Here we go. Here's my conflicts of interest. So my research program is supported by the NIDDK. I have served as a site PI and co-investigator for Novo Nordisk, but I have no financial support. And I will definitely be discussing off-label use of medications because we do that quite a bit in pediatric obesity medicine. So the objectives of today's talk are first to discuss pediatric obesity and the heterogeneity in response to treatments. And then to identify factors that have been associated with favorable outcomes to pediatric obesity treatments. And finally, to discuss precision medicine and characterize further opportunities for personalized treatment approaches to pediatric obesity. So let's start out with the first one, pediatric obesity, heterogeneity in response to treatments. We're going to go over some of this stuff relatively quickly, just because a lot of this stuff is things that myself and others in our group has talked about, but I definitely wanted to give some updates in this area. So again, pediatric obesity is defined as having a body mass index greater than the 95th percentile. And then there is a category called pediatric severe obesity. What pediatric severe obesity is it's having a body mass index of greater than 1.2 times the 95th percentile or a BMI of greater than 35. So if you can see my mouse here, you'll notice here is the usual 5th to 95th percentile lines that we're used to looking at. This is the 110th of the 95th, 120th, and so on and so forth. So this category known as pediatric severe obesity, where complications are higher, is this line right here or above, this 120 above the 95th percentile or a BMI of greater than 35. 20% of US children and adolescents currently have obesity, it's estimated. And that severe pediatric obesity category that we just talked about, this is the fastest growing obesity category. At least 6 to 8 million children in the year and adolescents in the US have severe pediatric obesity. These are also the kids, again, with the greatest risk for developing obesity-related health consequences, including things like NAFLD, type 2 diabetes, cardiovascular risk, etc. And unfortunately for these children, lifestyle modifications, just telling somebody to go out and diet and exercise, are generally ineffective. And I know that this is an older study right here, but in this study, they had about 640 children that were followed for 3 years. In a pediatric weight management clinic between the ages of 6 to 16. And of the children in that who had a severe obesity, this BMI greater than 1.2 times the 95th percentile, 98% of the times, just telling somebody to diet and exercise, lifestyle modification therapy did not work. So there are a lot of different causes when we look at the causes of carrying excess weight. And I like to really divide them into these two different categories. So the first one is what is known as the first one is known as our internal factors. We'll start out here first. So this includes things like our microbiome, our HPA axis, our mood, genetics, etc. These are all kind of the internal factors down here. And then up here are kind of what is known as risk regulators. So other things outside external factors, essentially. So things like the built environment, local food environment, food deserts, food swamps, parental influences, commercial messaging, cultural norms, socioeconomic status is a big one, right? And so these two things, they kind of work in on each other to influence feeding, and so eating and physical activity, which can then increase body weight over time. Put another way, there are a lot of different potential causes. So things like reduced metabolic rate, large portions, depression, functioning, race, ethnicity, weight cycling, poverty, et cetera, right? There's a lot of different potential causes. So in terms of treatments, there's kind of three major categories that are out there, and that includes lifestyle modifications, metabolic bariatric surgery, and anti-obesity medications. And we're only going to briefly talk about the first two. So in terms of lifestyle modifications, definitely this is the background for all treatments, and they include the things that we would generally think about, right? Decreasing fast food and added table sugar, high fructose corn syrup, decreasing high fat, high sodium or processed foods, reduce saturated dietary fat intake, eat the whole fruit rather than the fruit juices, eliminate sugar sweetened beverages, educate on portion control, follow USDA recommendations, try to avoid quote unquote grazing and focus on timely regular meals, recognize your eating cues, so things like boredom and stress and loneliness. And then there's another one that was on there as well too. It must have fallen off, but the bottom line is that, you know, I just wanted to very, very briefly go over kind of dietary principles. In terms of exercise, it's been recommended 60 minutes of moderate to vigorous physical activity a day. They say that it does not need to be accomplished in one session. One thing that I commonly do in clinics is I prescribe what is known as kind of a written prescription to engage in physical activity. So whenever I see a patient in clinic, we always talk about food goals and activity goals. And those activity goals is essentially a written prescription where I'm actually writing down for the patient, we'll do something X amount of times a week, X amount of minutes at a time, for example. There's also evidence about limiting non-academic screen time, and obviously shared decision-making is super important, right? If you're gonna take somebody who hasn't really been physically, you know, who is largely sedentary and tell them to go run an hour a day, obviously that's not gonna work very well. So shared decision-making is very important. Next, one slide on metabolic bariatric surgery.
I think Eric.
That any further, but just to let people know that this is definitely something that's out there. And finally, anti-obesity medications. So this right here is the list of anti-obesity medications that have been approved in adults. We will talk about kids, obviously, next. So you will see there are these ones. There was orlistat, phentermine and topiramate combination, naltrexone bupropion combination, liraglutide 3.0 milligrams daily, also known as Saxenda, and semaglutide 2.4 milligrams weekly, also known as Wegovy. One of the things you will notice is that most of these have come about within the last 10 years or so. And so our field in general is relatively new. The average weight loss, and now these are in randomized control trials, and what happens in the real life setting can be different. But in randomized control trials, we see from most of these medications, weight loss in general averages somewhere between 5 and 10% or so for most of these. But really the biggest bang for our buck has been one of the newer players out on the market, one called semaglutide 2.4 milligrams weekly, or Wegovy. And in adults, after a year, this led to an average of 16% weight loss compared to 5.7% for placebo. So this has been our biggest bang for about a buck for adults recently. In terms of current options that are approved, FDA approved in youth. Again, they're very similar to the adult studies. What tends to happen with a lot of these studies is that they first get approved in adults, and then they eventually move over to children, and then they eventually move over to younger children, which you'll see in a second. But the options that we currently have available in youth are phentermine, Orlistat again, liraglutide 3.0 milligrams daily, also known as Saxenda again, phentermine topiramate, and semaglutide 2.4 milligrams weekly. Once again, you will see that really a lot of these are pretty darn new on the market, right? Being approved between 2021 and Wegovy, that last one on the list, at the very, very end of 2022. So again, once again, of the current options that are FDA approved, semaglutide seems to, on average, and we're going to talk about on average quite a bit in a little bit here, but tends to be on average the best option that's out there. So there are other current anti-obesity medications that are currently in trials in various populations of children. And this includes the top one right here, which is the Saxenda or liraglutide 3.0 milligrams daily, which is a GLP-1 agonist. It's currently in studies in 6 to 12-year-olds. And this is the results from adult studies. So is average weight loss of about 8% after a year compared to 2.6% in placebo. Currently also in study right now, or about is a trial looking at semaglutide 2.04 milligrams or Wegovy weekly, now in down to age 6, so 6 to 18 years old. And again, we saw the average weight loss in adolescents being around 16% versus a gain of about 0.6% in the placebo group. A third one that's currently in studies right now is tirzepatide. Tirzepatide is a dual glucagon-like 1 peptide 1 and GIP receptor agonist. This is currently in studies in 12 to 18-year-olds, or just starting these studies right now. And if we look at the weight loss, the average or the mean weight loss in adults at the highest doses here, we're now up to 21% average. And so we're really starting to get into medications that are more and more and more effective. And so these are the current ones that are in trials in kids right now. Now, there are still others that are in trials in adults. And so these are 2 oral GLP-1 agonists. So again, semaglutide, this is a much higher dose that has been out there. So this is a 50 milligram oral pill of semaglutide that's currently in phase 3 trials. And again, this is oral as opposed to the other ones, which are injection. Over here is, early studies in adults showing an average weight loss of 15% after about a year compared to 2.4% in the placebo. This is another oral one that is currently in phase 2 trials in adults. And this is just after 16 weeks, we see about 5% loss or 4% loss compared to placebo. And then another one, which is what is known as a triple or a tri-agonist that also includes glucagon. So this is, again, GIP, GLP-1, and now glucagon. And this is currently also in phase 2 trials. And if we look here at the averages, now we're really starting to get up there, right? And so this is at least in after about a year in adults. But there's also a lot of other potential options that we do use. And so phentermine, topiramate, I guess you could use Orlistat, although we don't generally use that because it's not very effective. Phentermine and topiramate can be given separately. There's other GLP-1 agonists. There's a role for metformin, naltrexone by itself, naltrexone bupropion, tirzepatide, ADHD stimulant medications, specifically Vyvanse or lisdexamfetamine. So there is a lot of different potential options there. Now, one of the things that we do know is we had just focused a fair amount on talking about means or averages, right? The average weight loss in this randomized control trial was 5% or 10% or 15%. But one of the things that we do know is that when you look at the individuals, averages are just averages, right? Every individual person is going to be different. So this is from a paper from back in 2018, just looking at the heterogeneity, looking first at adult studies, right? And so this was looking at lifestyle modifications plus or minus anti-obesity medications. This is one called lorcaserin over here, which isn't used anymore because that came because that had some issues, and so that was taken off the market. But what we see here in general is we see that there's a very wide spread going all the way down from significant weight loss in some people to even weight gain in other people's with both medication and with placebo. We see the same thing too with treatments looking at supervised exercise. And again, we see the same thing looking at surgery, right? Roux-en-Y gastric bypass or sleeve gastrectomy. And so the take-home point is an average is an average, but every individual person is going to respond differently, right? Looking at pediatrics now. And so this is a study that we had done here published about 4 years ago. And this was looking at various interventions in pediatrics, so lifestyle, pharmacotherapy, and metabolic bariatric surgery from 3 different sites. So Minnesota, Arizona State, and Cincinnati Children's. And again, what we see is we see a huge spread in response, right? Some people, especially with metabolic bariatric surgery, losing up to 50%, some people gaining weight again, right? And so there's a huge spread. And again, if we look at the specific anti-obesity medication options, so here is one looking at liraglutide, again, showing the same spread. Here is one looking at exenatide, here's one looking at phentermine, and here's one looking at topiramate. And every single time we see the same thing happening, right? Which is some people do really well, and some people don't do really well, right? And so that's really kind of the major question that, we want to try to get at eventually. So what are some of these potential sources of heterogeneity? Well, there's genetics, physiological, behavioral, psychosocial, environmental. There's a lot of potential sources of heterogeneity. And it kind of feels like right now, a lot of what we're doing is kind of taking a trial and error approach, right? Shooting in the dark. So we start somebody on a medication. We tell somebody, here is the average weight loss that we have seen in clinical trials. It might be a little different in, in real world practice, but everybody's a little different. And we just start something and we kind of see. Can we do better than that? Well, I think we can, and that's kind of the major points or talking points of today, right? So the next part is that I really wanted to talk next about factors that have been found to be associated so far with favorable outcomes to pediatric obesity treatments. Take time here. Okay, perfect. Okay, so first, we have started to discover some of these factors that might be predictive or associated with response. And thus far, one of the major kind of, what I like to call here, a term that I stole from my research mentor, Aaron Kelly, is this term called primordial predictors, or just early predictors that we have started to see out there. One of the predictors that we have started to see with a lot of different interventions, which I'm going to show you in a second, is that early weight loss appears to predict greater weight loss. So this is one example of a study. In this study, this looked at this is a study that was done by Amy Gross in our group and others. This looked at about 700 kids who were between 4 to 18 years old that were followed in 31 different pediatric weight management clinics around the country. And really they wanted to see if 1 month improvement in BMI or 1 month weight loss predicts greater 6 and 12-month weight loss. And yes, they did find that in general, those who, that on average, those who lost at least 3% of their body weight at 1 month had greater odds of continuing to respond at 6 and 12 months. That's just one study. There was a study looking at, this is in adults right here. So this was looking at liraglutide. And again, this is the objective here was to compare early responders, which in this case was defined as those who had lost at least 4% of their body weight by 16 weeks, and compare them with non-responders. And again, they found greater weight loss at 56 weeks in those who responded earlier versus those who did not respond earlier. And finally, very recently, Meg Benson here, also from our group, and myself and others, did another study looking at predictors of response to liraglutide in 10 to 17-year-olds. with overweight or obesity with or without type 2 diabetes. And in this study, this was a secondary analysis of a randomized control trial that was done. The objective here, again, was to identify baseline characteristics that are predictive of achieving at least 5% and at least 10% BMI reduction at 56 weeks with liraglutide versus placebo. And once again, we found that those who responded earlier have greater BMI and body weight reductions later on. So that's kind of one of the major kind of quote unquote primordial predictors that we have found so far. But there's been a couple of other studies that have been out there that have found perhaps a few others to specific medications or specific treatments. And so this is a study that was done back in 2016 looking at 27 adults who were started on phentermine for 8 weeks. And in this study, they found that those who had higher baseline hunger and lower baseline cognitive restraint tend to respond better to phentermine, right? And so these might be other potential predictors of response, at least to phentermine. This is a study that our primary author here was Brandon Nathan, again from our group. And this was looking at 32 adolescents who were treated with exenatide, which is another one of the GLP-1 agonists. In this study, they wanted to evaluate predictors of 3-month weight loss response. So this was done quite a bit ago. And in this study, we found that females and those with higher baseline appetite tended to tended to have greater weight loss response at 3 months. So a couple of other primordial predictors. There was another study that was done in 2017 showing that those with higher eating disorder pathology tended to have less weight loss among 7 to 11-year-olds with overweight obesity who were treated in a family-based behavioral weight loss treatment program. So again, we've seen a number of these quote unquote primordial predictors, right? We're starting to identify or understand that certain factors might help predict who is going to respond to specific medications. And so we do seem to see that early weight loss tends to predict greater weight loss. Perhaps sex may play a role. There's differences in leptin levels between the sex, and there's a lot of different thoughts about that. So there's a lot of different potential factors, eating disorder pathology, higher degrees of hunger, that might predict whether or not somebody is going to respond better than others. So with that being said, now that we're kind of at the very beginning or at the forefront of trying to figure out what some of these predictors are, I wanted to discuss next precision medicine and to talk about future opportunities for personalized treatment approaches to pediatric obesity, which is one of the major kind of goals of my research program. So what is precision medicine? Precision medicine is an emerging approach for disease treatment and prevention that accounts for individual variability in genes, environment, and lifestyle for each person. And so this is the definition that comes from the National Institute of Health. It's really about trying to identify and characterize what are some of those sources of heterogeneity, and to take all of this information to help us select the best appropriate treatment that really maximizes benefits and minimizes risk for that individual person. And so really this gets at trying to figure out what the right treatment is for the right person at the right time. So back in 2018, there was an NIH workshop that was focused on, as you can see here, precision medicine approaches to the treatment of pediatric or severe obesity in adolescents. That was done back in 2017. And really this group got together, which included Aaron Kelly again, to get a bunch of experts together to say, hey, what are the gaps? What are some of our opportunities? What do we need to do for future research? I talk here about tailored treatment strategies may be developed by achieving a better understanding of individual differences in things like genetics, clinical, metabolic, psychological, and behavioral phenotypes, and response to environmental exposure. So this group identified what is this? 1, 2, 3, 4, 5, 6, 7, 8 different things, right? So the need to uncover these phenotypic factors predicting response. The need to use genomics approaches to develop precision treatments, to optimize medication dosing based on an individual's metabolism, to determine the best metrics to assess weight and adiposity in severe obesity, to develop the best measures for factors that are promoting weight gain. In other words, some people, when they start various medications, for example, atypical antipsychotics, they may gain a lot of weight after starting a medication. It may really affect their appetite, and some people not so much, right? And so we want to kind of figure out what some of those are. To better understand the mechanisms and biopsychosocial predictors of obesity, we need to standardize research outcomes and results reporting, and to identify individuals who can be effectively managed in the primary care setting. I wanted to focus on these 3 right here because these are kind of the primary focus, I guess, of my research program, is the uncovering phenotypic factors, predicting response using genomics approaches to develop precision treatments, and optimizing medication dosing based upon an individual's metabolism. And next, I'm going to kind of talk about the various things that we're doing to look at these different factors. So let's start out with uncovering phenotypic factors predicting response. One technique or tool that we can use to kind of get at that, and one of the major things that I do in my research program is to look at the use of EHR data or clinical informatics. So what is clinical informatics? Clinical informatics is the scientific, quote unquote, scientific and medical field that concerns itself with cognitive, information processing, and communication tasks of medical practice, education, and research, including the information science and technology to support these tasks. So it's basically the tools and techniques to be able to use our electronic health record for clinical research. So in general, the EHRs are rampant. They're all over the place. There's been a huge growth of data that's available in the EHR. We now have a bunch of different research tools and techniques that we can use, and we can combine all of those things together to really enhance clinical discovery, which is especially pertinent in pediatrics and in rare diseases. So where there are smaller sample sizes, fewer studies available, et cetera. So this is one thing that we do a fair amount of. Taken another way, really, in the EHR, we have a lot of different pieces of data, right? Diagnoses, vital signs, progress notes, medications, labs, et cetera. We want to extract those. We want to validate those. We want to merge those together into a final data set. We want to analyze those, right? And so that's kind of the general approach. Sounds easy, but in practicality, there's a lot of things to think about. What are some of those things? Right. One of the major things that we do know is that data can be collected at random times in random settings. And so we can have a lot of issues with missing data. That is because when patients are seen clinically, the goal here was not necessarily to do a research study. It was to see and help people, right? And so data is not necessarily collected for research purposes. And therefore, for example, you might be interested in a specific outcome at 6 months, but you only have baseline and 9-month data available. You also have to consider that, where the data was collected from. Was it collected from an inpatient encounter, from an ED, from an outpatient setting? You want to, you might be looking at a specific population with inclusion exclusion criteria, but you may not have that stuff available in the EHR. There's also, the EHR also has a lot of free text elements, which can be much more challenging to deal with as well too, but there are health informatics approaches that can be used to abstract some of that data. And obviously during COVID-19, we had a lot of home measurements, and there's obviously concerns about those being less accurate than in weight. And so there's a lot of difficulties that we have to at least consider. Really what this kind of the use of clinical informatics or EHR enabled clinical discovery tries to get at is it tries to get at avoiding this concept known as data fishing, right? And so data, so these EHRs, they have massive amounts of data in them. And it is certainly possible that if we were to run every association under the sun, we're going to find a lot of different things that can be positive, right? And if we do that, we're going to, if we don't set out ahead of time exactly what we're going to look at and exactly how we're going to do it, we might find a lot of things that are statistically significant, but they make no sense, or they're just not backed up by any, rationale, essentially. So really what we try to do is we try to, this is a hypothesis generating tool that you have to come up with a well thought out plan. And by doing so, you can really reduce this type 1 error. So there's a lot of different elements that one wants to pre-specify or think about if they're going to be doing an EHR study. So you want to think about and you want to design all of these things ahead of time, I believe. So, what is your significance? What is your objectives with that study? What are your hypotheses? What's your design? What variables are you going to include? What are your inclusion exclusion criteria going to be? What is your plan? How are you going to secure your data? What timeline are you looking at? Because these sort of studies have a way of just dragging out forever unless you kind of set some timelines for yourself, and obviously ethical considerations because we are looking at EHR data. So here are just some examples of different studies that we have done this in. This was looking at the use of phentermine in pediatrics, which we have recently submitted. And what we wanted to do with this study is try to figure out what the kind of the real world impacts of phentermine, so phentermine being used in a real world setting, and what are some factors that might be associated with weight loss response. So we had around 90 patients over an 8-year period that were treated with phentermine, and what we found is that on average, after about 6 months, the average change in percent body mass index was down by about 12 points. And the average change in body mass index itself was down by about, after 6 points. It really, kind of effects seem to have kind of reached their peak or maximal effect around 6 months or so. And again, we see a drop of about 2.5 points in BMI reduction with phentermine. And we found that ALT and food responsiveness, which is also known as eating in response to external cues at these various time points, were associated with response. So we found specifically that having a higher ALT or having an abnormal ALT was associated with worse response. And in terms of food responsiveness, so having higher food responsiveness was also associated with worse response. And kind of the general, studies are obviously going to have to be done further, longitudinal prospective studies are going to have to be done in order to confirm these. But kind of our general rationale or thought right now is that in terms of ALT, having a higher ALT means potentially liver inflammation, and that might cause your response to be a little bit worse. In terms of food responsiveness, this is again eating in response to external cues. We do know that phentermine is a appetite suppressant, hunger internal cue, and so maybe this is, so maybe phentermine is not really working on food responsiveness, and so that might predict response. But again, this stuff is going to need to be validated, and this is one example of a study that we did. Another example is looking at topiramate. And so in this study, we kind of found very similar things as well too. And so this one will be presented at the Obesity Society later this year. And we're currently working on the manuscript for this. We found things that are relatively similar. This time, we see here kind of weight response at 3, 6, and 12 months, and we see that percent body mass index came down after about by about 9 points on average after about 6 months here. And in here again, body mass index change was about 2.5 kilograms after about 6 months or so. And in this study, we looked at various baseline characteristics that, again, we specified a priori ahead of time, and we really didn't find any baseline characteristics that were associated with response to topiramate. Now, our group is looking at, we've applied these techniques to other studies out there. So, for example, I published a study last year looking at anti-obesity medication rates by race ethnicity, and we found that anti-obesity medication prescription weights were lower in Hispanic Latino versus non-Hispanic whites. And if you used an interpreter, if English was not your primary language, it was associated with higher prescription rates. And obviously there's other anti-obesity medications that we plan to look at. So GLP-1 agonists that we've already started to look at. We use a fair amount of stimulants, specifically lisdexamfetamine or others. So next, I wanted to talk about genomics approaches to develop precision treatments and what we're doing to target this specific need. So one of the major things that we've been looking at is genetic risk scores. What are genetic risk scores? Genetic risk scores are estimates of genetic risk that are based upon the presence of multiple genetic variants. And they are developed from genome-wide association studies of quantitative traits or diseases. So there are a lot of different single nucleotide peptides or SNPs that have been associated with body mass index. And we do know that, maybe having this variant may increase your risk by 0.0001% of having a higher BMI, and this one by 0.001%, and this one by 0.001%. But if we take all of those together and we all add them up, now we're getting into, maybe a genetic risk score might predict 5% response or 10% response or something more real than a 0.001%. So it's a better way to estimate risk than looking at individual SNPs. So we're doing a couple of different studies right now that are currently ongoing. One of them is looking at participants who had undergone metabolic bariatric surgery. And so this is a group of around 260 patients from a cohort called the Teen Labs, which is the largest cohort in adolescent bariatric surgery. And one of the things that they found in this cohort is that, so this is, so they had bariatric surgery, and we see that everybody loses weight after the procedure, right? In general, most people lose weight, but we see that there's one group where, they lose a little bit less, and then they kind of, by about 4 years or so, they're back to about 4 years or so, they're kind of back to baseline, and it just didn't really do much, right? And so by 10 years out, they're higher than they were before. There's this other group, they lost some weight, and they still had some effect 10 years out, but it wasn't quite as great. Same thing here. And then there's this one group, they have a great response after about a year. And that response still continues after 10 years. And so we have seen that there's kind of these 4 unique weight maintenance phenotypes after 10 years. And one of the questions that we're trying to answer is if a body mass index GRS can explain these different weight loss trajectories to bariatric surgery. So we're actually doing something similar as well too with topiramate. So topiramate, it is the most commonly prescribed medication in pediatric weight loss and pediatric weight management clinics. Again, there's a super huge wide variation in response. Some people will start this medication, it does nothing. Some people start this medication and they do tremendously well. And so we're looking at various questions like, can a body mass index GRS predict your response? Specifically for topiramate, if we were to really focus in on those gene pathways that are involved in topiramate-induced weight improvement. So, for example, we do know that topiramate seems to have effects on GABA, and it seems to have effects on glutamate, and it's a carbonic anhydrase inhibitor. And so, if we were to look at some of the genes and the pathways involved in that, does that help us predict response? And ultimately, we may look at applying these to other anti-obesity medications as well, too. And so, finally, the third thing that our group is currently looking at is this concept of optimizing medication dosing based on an individual's metabolism. This gets into a field that's called pharmacometrics. So pharmacometrics is an emerging field that can help identify optimal dosing regimens for medications. And it combines 2 different things. It combines something called pharmacokinetics, which is what is known as the drug-dose exposure relationships, and pharmacodynamics, which is what's known as the exposure response relationships. So in other words, we take a medication, and that medication has a specific dose. And when we take that medication, we then have a concentration of that medication in our body. Now, there are certain variables, so whether it be ancestry, whether it be your starting BMI, whether it be your kidney function, your liver function, eating behaviors, etc., that really can impact some of those relationships between the dose and the concentration of your body, and that's pharmacokinetics. And then once you have a concentration of that in your body, how does that concentration, how is that related to the response that you ultimately get? And that is what is known as pharmacodynamics. And so there's modeling that really combines these two things. And in the past, these PK/PD studies or pharmacometric studies have explained some of the differential response to anti-obesity medications in adults, and they have been used to help identify optimal dosing of regimens to a wide variety of medications. Now, one of the things that we do know is that safety PK/PD studies or safety pharmacometric studies on new medications are generally recommended by the FDA. And so there's been some studies out there looking at phentermine, topiramate, for example. They found that the exposure in adolescents was comparable to adults. And similar to with liraglutide, where again, exposure in youth was similar to adults. And here it seemed that body weight was the most important thing that affected exposure. But in terms of kids, right, really studies evaluating these dose exposure response relationships with off-label medications, especially in adolescents, are lacking. And that is because, again, they're not required by the FDA approved, or they're not required by the FDA. So the FDA is not requiring somebody to go out and do a PK/PD study looking at topiramate for weight loss, for example, because that's off-label. And so topiramate is one that we're currently studying right now, but obviously we need to evaluate others. And I think that this is really important in adolescents because we do use a lot of off-label medications where these sort of things are not necessarily, going to be mandated by the FDA, for example. Another thing as well, too, that I've noticed is that when you look at some of the anti-obesity medication PK/PD studies in pediatrics, they often do not necessarily consider clinically useful response metrics. So they may look at something like the body mass index standard deviation score, when really there's other metrics that might be better to look at. So body composition is relatively easy to measure. We do know that body composition seems to be more predictive than body weight when you look at various PK/PD studies. And so there's a lot of different potential opportunities out there. Now, there are other precision medicine approaches out there, and the ones that I've highlighted here are others that either myself or others in our group are currently looking at. So patient-reported measures, measures of food preferences and hunger and satiety, looking at functional neuroimaging. We've started to at least delve in or think about things like the microbiome and metabolomics, epigenetics. So there's a lot of pharmacogenomics is specifically looking at gene response to medications. Or how genes play into that response, essentially. And so there's a lot of different other approaches that are currently out there. So in general, I think that there's a lot of challenges and opportunities when we think about precision medicine, right? Obesity is a very complex disease. There's a lack of standardization, which really limits our opportunities for combining data. There's been groups that have been trying to get at that lack of standardization, really to come up with common measures and techniques. For example, this thing called the ADOPT project. We want to design trials with the intent to address predictors because oftentimes a lot of our studies are designed or powered to look at the overall response, but not necessarily the variability around that response. And so that's something that we want to think about. And we also want to think about side effects as well, too, the other half of things, right? So who is more likely to develop specific side effects or adverse events? And for these sort of things, because side effects in general tend to be more rare overall, you need larger sample size. So really, I think kind of a take-home point is despite efforts to advance the fields of precision medicine, we have to acknowledge that really multifaceted treatment approaches are going to be required to help most people achieve meaningful and durable weight loss. So with that being said, we talked about a number of different things today. So again, to kind of summarize things, pediatric severe obesity, that's how it is defined up there. BMI greater than the 95th percentile, or greater than 1/20th of the 95th percentile, or a BMI of greater than 35. There are multifactorial causes and a lot of different treatment options that we discussed today. There is a large amount of variability in pediatric obesity treatment outcomes. And we have started to really identify what some of these early predictors are, these quote unquote primordial predictors. So early weight loss, increased hunger, eating disorder pathology have been shown to be associated with response to various different interventions out there. It is likely that the sources of this heterogeneity are multifactorial and complex. And finally, that the field of precision pediatric obesity medicine is really in its infancy. And so there's several potential tools and techniques. I talked about just 3 of them that our group is currently working on. And really, there's a long way to go here. So with that being said, I'd like to now go back again to our final slide and thank everybody, thank the NIDDK for their support, thank the division and the department for their support, thank CPOM and everything, everything that CPOM does for their support as well too. And with that, I'll take questions.
For those who are at home, feel free to put your questions in the chat. I can read them out, or Dr. Bomberg can respond directly. I have a question about the EHR informatics approach. Just as a primary care pediatrician, I can see there's a lot of information being put in by our patients about 5210, basically. They're being asked if they eat fruits and vegetables. They're being asked if they get 60 minutes of exercise a day. Have you tried looking at those big data sets, or are you aware of other literature to see, can you use that patient? I mean, you alluded to this. I just was curious to hear you expound on it more. Like what, and of course you also said we shouldn't go blindly digging in there and find things. So just that interaction between what they're putting in a primary care visit and what we could learn from it.
Yeah, we have not actually looked at that at this point. Most of the stuff that we have been looking at specifically has either been related to anti-obesity pharmacotherapies or specifically kind of, data within the weight management clinic pool. So our pediatric weight management clinic is huge. I mean, we have something like 8 different providers, a fellowship program. We see people almost every day of the week. And we've been primarily really focused on kind of our pediatric weight management clinic pool, but I do think it's an excellent idea for sure. Definitely something I haven't thought about before. And I think, yeah, you are correct. We are indeed collecting a lot of, if you look at, I see those primary progress notes all the time whenever I'm looking at, preparing for a clinic, and yeah, you see all of that stuff, and we haven't actually looked at that.
Great. Looks like Dr. Miller maybe has a question for you in the room. He's raised his hand and maybe his real hand.
We have a great audience here in the Wilf Center today. I apologize. My intent was to have this be a well-attended in-person meeting, but there was some confusion about whether we were going to be in person and have breakfast and those sorts of things because of a change in how we're coming back in
coming
person,
out of COVID.
So my goal was to have a huge audience here today. And I'm glad that we have an audience online. But my question for Eric actually relates to some of his data and some of my work related to growth. And I noticed that in one of your slides at 6 months, you had 40% of your patients or 41% of your patients that started. And so to some degree, it's a survivor curve of responders. And I think that your work to look at genetic risk scores for response is huge, predictive scores for pharmacometrics. But I also think there's, as you mentioned, multidisciplinary, multiple approaches to understand why people don't persist in their treatment. And so I'm wondering how much that affects your research, because you're looking at a responder curve. You're essentially only keeping the ones who stuck around. And so how does your approach to understanding your results take that into effect.
Yes, that is an excellent point as well, too. Observational studies in general, whether it be EHR studies or anything that is observational, is never going to be perfect. And one of the things that we do know is that this is not a randomized control trial. You're going to have patients that are going to come in at various time points. They're going to maybe come in at 3 months. They maybe won't come in for a year. They'll maybe be lost to follow-up. And so certainly it is possible that some of these results may be biased towards a better effect, but I'll talk about how we get around that in a second. So, for example, if you saw 100 patients in clinic and 100 patients were started on topiramate, I'm just giving a random example with made up numbers, but you were to start 100 people on, 100 people get started on topiramate in the clinics, and only 50% follow up. Right? So, what happened to those other 50% of people? Well, did they not respond as well, and therefore they just never came back? That is certainly possible, yes, right? And therefore, it could be that some of the results that we're seeing in some of those slides are more biased towards a better effect, because we're seeing people that are probably more likely to come back, or probably responding better because they're coming back. So one of the things that we actually have analyzed separately is we've specifically looked at what was the starting metrics or starting body mass index and weight and et cetera in those who did have follow-up data on. And so so taking the, let's just take that example of 100 participants. Let's say that we have 75 who had 3-month data, and then we had 50 who had 6-month data. So we may look at just those 75. What was their starting BMI, just those 50, and what was their starting BMI.
Yeah.
But again, things are definitely not going to be perfect. And all of these studies, these are all about a hypothesis. This is a hypothesis generating tool.
Yeah.
And definitely randomized control trials are better.
And I know you're doing a lot of work in terms of capturing the social determinants, the environmental determinants through questionnaires, through food-related questionnaires as well. So have you already, or are other people doing this, where they're taking some of the non-genetic predictors of response and trying to hybridize those with genetic risk score? So a qualitative predictor in the environmental or social of response versus the others. Is that been done?
Yes, we are also looking at that as well too. So, for example, one of the studies that I'm looking at right now, or one of the studies I'm currently working on right now, is looking at whether or not a genetic risk score predicts response to topiramate. But we're also looking at, with that as well too, we're also looking at things like eating behaviors, sex, baseline, BMI, et cetera. So we're also looking at all of those other things as well too.
Got it. No, I think it's, as you mentioned, it's a complex, multi-factorial issue, and so I think the psychology, the environment also needs to be taken in with the genetic risk scores, because in many circumstances, in the growth area, kids stop their treatment because insurance stops providing it, and that has nothing to do with their genetics.
Yes.
And so I think that's one of the challenges that we have to look at. The other thing that I thought was really important in your work was looking at the 1-month response or the 3-month response, because trying to identify the early responders and the early failures, I think, is really important in our treatment of any condition. And so I think as much as you can to focus on how can you predict which child will respond to what, but also as they're on treatment, how can you decide early that something is working or it isn't, and why, I think are also key. So
yeah, and I think that early response also too is important, just because you know, I mean, people can, especially in pediatric weight management, people can get very discouraged very quickly.
yes.
And so that's why you really want to try to, you know, this field is very much in its infancy, and you really want to try to figure out, you know, the ultimate goal here is to start somebody on the medication that's most likely to be effective for them at treatment onset, because again, yeah, people can get very discouraged later on.
Looks like Jordan has a question. Ozempic is touted as a wonder drug in the public eye for weight loss. Does this help the job in weight management drug? And do you perceive a downside to the Ozempic press? That'll be our last question, because I think we're running out of time.
Yes. So Ozempic is definitely out there in the press, in the publicity quite a bit. It's been touted by a lot of different people. Semaglutide. Now, Ozempic is the same thing basically as Wegovy. It's just a different indication. It's approved for type 2 diabetes, where Wegovy is approved for weight management. The doses are slightly different. I do think that of the current options that are currently available right now, on average, it does seem to be the one that is most effective for sure. It is a very, very good treatment. There's a lot of challenges in general with getting the medication, just because there's been national supply chain shortage issues everywhere. That's number one. And number two is that insurance coverage has been extremely challenging for these medications. So I do think that it is good. But again, you know, we do see a very wide variety of response. For example, I have a 25-year-old adult that I started on a smaller dose, 0.5 milligram dose, who lost 200 pounds after starting. And I've had people who have been on the full 2.4 milligram dose of Wegovy and have lost, you know, started out at 350 pounds. And after a year, we're at 345 pounds or 340 pounds.
Is there any downside to this press?
Yes, well, yes, I do believe that there is downside to the press. You know, I always say that no medication magically causes weight to disappear, right? Medications are really meant to work on signaling, right? And so if your signal is high degrees of hunger, if your signal is binge eating tendencies, cravings, low levels of satiety, whatever that happens to be, they're meant to work on that signal, but they will not work in a vacuum. And so I do think that really kind of working with people who are experienced in the use of these medications, and kind of doing it through you know, kind of an approach that is not just, let me just order this up on the internet and start this and hope that this is going to be magical, but really kind of doing this, you know, kind of in a more clinical and scientific approach, I think is super important.
Great. Emily, do you want to wrap up? Thanks to everybody for joining, and for Eric for an excellent presentation.
Yeah, and I just wanted to, it's been like 4 years, I think, since I've done ground rounds, and just knowing the audience, I wanted to kind of talk a little bit about kind of the research program that we're doing, you know, where I was looking for expanding our center and our collaboration. So.
Great. Well, thank you so much for a great talk. Have a great Wednesday, everyone, and we'll see you back next week. Bye.
Thank you.
Thank you.